All right, folks. Good evening, and yeah, welcome to this session of Therapy Ed's online office hours. My name is Tom Sutlive. I'm going to be the instructor for tonight, and we got still got a number of people that are kind of trickling in, and I'll get them all checked in and everything, but. We want to try to stay as much to schedule as possible. So we're going to go ahead and get started. As you may have noticed in the chat box, this session is going to be recorded and it's going to be posted to Therapy Ed's PT or the PT YouTube channel. And so you'll have an opportunity to go back and take a look at this at a later time if you would like to do that, and if that helps you in terms of your study preparation. We are going to be talking about interventions for the musculoskeletal system this evening. And just a little bit about myself. So I am on faculty here in San Antonio, Texas, in the Army Baylor University DPT program. I've been on faculty here now for about 25 years. I served on active duty as a physical therapist in the Army as well for right around 23 years. And yeah, I love what I do, love working with students like yourselves. I teach primarily the foundational sciences in the program now. I had gone back and gotten a PhD in anatomy, and so that's the content that I teach primarily. But I've been with Therapy Ed since 2011. I started off by teaching their 2-day prep course. A number of you may have attended the 2-day prep course in the past. And then a few years ago, I became one of the co-editors for Therapy Ed's review and study guide. So I suspect that some of y'all have that as a resource to help you prepare for the NPTE. If we could y'all go ahead and light up the chat box and let me know and let everybody else know, I guess, when you're planning to take the NPTE? Great. Okay, July. I suspect a number of people are going to be taking it in July. Some of you, okay, April. I see a bunch of Aprils right there in a row. So a number of you are going to be taking the exam in just a few weeks. Sarah and Jazzy, I can see that y'all aren't going to be taking the exam until sometime in 2025. So no substitute for early preparation. And I think it's good that you're working on getting in your reps early. And so awesome. So Eden, okay, so I see you're actually in Canada. You're not going to be taking the NPTE, but you're going to be taking the PCE. And so well, hopefully you'll find these online office hours to be helpful for you in your preparation as well. So real quickly, the focus for this evening, we're going to focus on the musculoskeletal system, and in particular, interventions questions. So my experience has been, in teaching DPT students for a number of years, and then teaching this prep course for a number of years as well, is that the intervention section can be a little bit of a challenge. That is, we have a pretty good handle on, taking a good history, doing special tests, doing a thorough physical examination, coming up with a diagnosis. And then we kind of get to that point where it's like, okay, now what do I do with the patient, Or as it relates to the NPTE, what are those examination questions going to look like, and what are they going to look like in terms of interventions, and how I address certain findings in the question stem and those kind of things. And so that's really a little bit of the premise for why I chose this topic, a little bit of background for why I chose this topic. And of course, we're going to integrate this information and relate it to the kind of questions that you're potentially going to see on the national licensure exam, whether you're taking the exam here or whether you're taking the examination in Canada. For the NPTE, and y'all have access to all this information You can see the link down at the very bottom of this slide. You can go to the fsbpt.org website and find the content outline and the breakdown of questions for each one of the categories, each one of the systems, each one of the domains that you're going to see on the exam. This, if you take a look at this slide, of course, this is only part of the information. This is the system categories that you're going to see on the exam. But we also know there are some non-system categories like equipment and devices and safety and research and EBP and those topics. And so I chose not to do the comprehensive overview. We're focusing on the musculoskeletal system tonight. And so that's what I've got highlighted in the box. And as we take a look at this slide, we know that the musculoskeletal system is one of the big three categories on the examination. The musculoskeletal system, neuromuscular systems, and cardiovascular and pulmonary systems account for about 65% of the examination. So that's 2 out of every 3 questions on the examination. You can expect to be the basis or the foundation for those questions to be one of these 3 systems. If we take a closer look at what is highlighted here in the musculoskeletal system, we can see there's a fairly even distribution. There's going to be about 16 questions on examination of the patient that has musculoskeletal disorders or a musculoskeletal disorder, about 16 questions related to evaluation, differential diagnosis, and prognosis, and then about 17 related to intervention. So we don't know exactly how many questions. The folks at the FSBPT give us a range. So the number that is in parentheses under the kind of midpoint value here, those numbers are provided by the FSBPT, and we just we choose a number in the middle. We can guess that there's going to be about 17 questions related to interventions for patients with musculoskeletal disorders. If you wanted to take a closer look at this information and exactly what is published by the folks at the Federation, then you can go to their website. Again, that's listed at the very bottom of this slide, and you can look at the specifics that are listed there. So I've done a little bit of this. A good chunk of this is going to be based on my experience and others' experience, folks that I've worked with that have worked for a long time helping students prepare for the licensure exam. But a little bit of what you're going to see on this slide is going to be some speculation as well. So what are, I'm just brainstorming here, but what are some potential questions? What could they be based on with regards to musculoskeletal interventions? Well, you could have questions that are based on, impairment. So in the question stem, there's a description of some impairments that the patient that presents with. And then what you would have to do is identify the best intervention, the best treatment based on the impairments that are described in the front part of the question or the top part of the question. Timelines, right? And I always tell students this when I present a 2-day prep course. If the author of an exam question or a simulated examination question made the effort to include a time frame within the question stem, then that's probably going to be an important part of answering the question and getting the question correct, right? What we do 2 days after an ACL reconstruction is much different after after 2 weeks or even 2 months post-op from an ACL reconstruction. So we got to take into consideration things like the stages of soft tissue healing and maybe even protocols to an extent, that kind of thing. But timelines There could be questions that are based on timelines. Then diagnosis, maybe you're given a specific diagnosis, like this person has had an ACL tear or has Achilles tendinopathy. They have some specific type of disorder. It's been specified in the question stem, and then we have to identify an appropriate treatment based on the diagnosis that has been specified. It's always nice, right? It's always nice when you don't have to guess what the diagnosis is. It actually tells you that up front in the question stem, and then you just have to identify what the appropriate intervention is. Clinical practice guidelines, we're going to see a question tonight based on clinical practice guidelines. And so what is the evidence related to, to certain conditions, to maybe the person with non-arthritic hip pain or the person with an Achilles tendinopathy or ankle sprain or something along those lines. Something else that I often say during the course is, the clinical practice guidelines themselves are not, they are not testable per se on the NPTE, but the information that is in the clinical practice guidelines is testable. And I know that sounds like maybe a little bit of a silly statement. We know that the examination that you're going to take is based on information that is published in textbooks. Well, it's likely that a lot of the information that appears in clinical practice guidelines has also already been published in textbooks. So the nice thing about the CPGs is they provide one-stop shopping, right? One-stop shopping, everything you want to know about adhesive capsulitis, the best way to examine the patient, what leads to the diagnosis, and interventions for adhesive capsulitis. As an example, there's a clinical practice guideline for that. So they're wonderful, and we'll talk a little bit more about them later. Safety, got to be able to recognize, red flags. Does this person have acute anterior compartment syndrome? Do they have a fracture? Is there some safety component that is involved with us recognizing and making sure that we get the patient treated in a timely manner and in a safe manner? Clinical prediction rules. So for instance, the Ottawa knee rules, the Ottawa foot and ankle rules. There's clinical prediction rules for when to manipulate somebody with acute low back pain. And so clinical prediction rules would be something to, a question could be based on as well. What else? Principles like the centralization phenomenon, right? Or again, protocols may kind of come into play, but we want to recognize that, there are some principles like the idea of centralization or peripheralization that is really going to guide our clinical decision making and guide our decision making in terms of answering questions as well. Exercise prescription. So a question may say, your patient presents with, 3- or 2- manual muscle test or a 3+ manual muscle test. What is going to be the most appropriate exercise or the parameters for exercise prescription? Those kind of things. Post-operative scenarios, maybe you'll be presented with somebody that had a total knee or a total hip or an ACL reconstruction, and we got to think about what are going to be the appropriate and timely interventions in that case. Pharmacology, that can certainly come into play as well. And then new for the examination that y'all are going to take, and new starting in January 2024, was regenerative medicine procedures. So things like PRP plasma, platelet-rich plasma injections, ACI and MACI, so autologous chondrocyte implantation, and we're going to see a question that deals with one of those a little bit later this evening. So I don't want to say too much more about it right now. And so with that, again, this is just a little bit of brainstorming. Some of it is based on experience. Some of it's going to be based on content outline. and just kind of guessing and again brainstorming as to what are some potential questions that we might see on the examination. And with that, let's just go ahead and start getting some repetitions in, right? Let's start looking at some questions. Uh, I'm going to go ahead and bring questions up one at a time. And what I want y'all to do is I'm going to put up a poll for you to answer the questions. And so you'll have about a minute to review. Yeah, about a minute to review the questions. Let me see if I can get sorry, I got to get my poll up here where at least where I can see it for the time being. I'll give you about 30 seconds, 40 seconds to read each question undisturbed and without the poll sitting right there. And then y'all go ahead and chime in with your answers, and then we'll go ahead and talk about them. Does anybody have any questions before we start actually answering questions? Okay, and we got about 7 questions that we're going to take a look at tonight. And so I think what you're going to see is a fairly representative sample of what you might see on the NPTE. All right, here we go. Question number 1. Yeah, you should be able to see the poll now. Okay, take a few seconds to finish up, get your answers in if you haven't done so already. All right, so we got just about everybody has responded. I'm going to go ahead and share the results with y'all. Y'all can see that most of you chose B. C was a fairly popular second best answer on this one, and we'll see what the correct answer is in just a minute. So in the red font, I've brought in some things that just kind of highlight some of the key words. Although the question stem actually tells us that the PT suspects adhesive capsulitis, but they had this 2-month history of progressively worsening shoulder pain, no known trauma or injury, and now they've got this limited motion. They're unable to move the upper extremity above the level with the shoulder. So we have to identify the best choice of PT interventions, and the best choice is actually stretching exercises. And this is based on the evidence. This has been based on what is published, as you can see on this slide, in the clinical practice guidelines. Okay. And so for us, I mean, you can look at the evidence up there, grade A, corticosteroid injections. That's not something that we as PTs do. We may work in close conjunction with orthopedic surgeon or another physician, somebody who has done an injection, and get the rehab started immediately afterwards. But for us, patient education and stretching actually trump. So that's grade B evidence. So that trumps mobilization and modalities. So this is a kind of question that you may actually see on the exam, testing your knowledge of the evidence. And the APTA has a number of clinical practice guidelines, right? And what is shown here or what is listed here is by no means exhaustive. I think there's probably about 4 or 5 more. you can go to so that you can see the jospt.org website if you want to take a look at these clinical practice guidelines. Again, most of them have been the material that you'll see presented, and most of them has been published in textbooks, which makes them fair game for the national licensure exam. Let's see, what else to share with this? If you have the Therapy Ed Review and Study Guide, so let me find my copy right here. Yep, if you have this book right here, it's kind of blurring on me, I know, but Therapy Ed's Review and Study Guide, our big book, then you'll see in chapter 2, the musculoskeletal chapter, Mike Crow and Brad Traeger, the authors, have done a wonderful job of boiling down these long articles, these articles that end up being 60 pages, 80 pages or so, and they condense the key findings from the CPGs into about a one-page summary. In the case of low back pain and neck pain, maybe it's a little bit more than a one-page summary. And so I encourage y'all to study these. Again, this makes for good one-stop shopping for at least for the topics that have been covered in these JOSPT or APTA published clinical practice guidelines. All right, let's go ahead and move on to question number 2. So here's the poll. And again, take about 10 or 15 seconds to get your answers in. All right, and I'm going to go ahead and move on. Give you a minute to answer the question, and then maybe about 10 or 15 seconds to actually submit your answer. So just try to get it done in that time. So let me go ahead and share the results on this one. So the second, again, number 2 was the most popular choice here. Let's go ahead and take a look at the important information with this question. We know this person has Achilles tendinopathy. There's a little, some of the behavior of the patient's pain is described here. They report initial pain when running that resolves after a half mile, but then it returns a few hours after running. So the severity and irritability isn't real high. It's fairly low. But the question is, which is the best intervention to decrease pain and improve function in a patient with Achilles tendinopathy? And the correct answer on this one is what most of y'all chose. So well done. About 70% of you got this one correct. There's actually strong evidence. Again, there's an Achilles tendinopathy CPG, but there's strong evidence to support the eccentric loading of the ankle plantar flexors to decrease pain and increase function in patients with a disorder. This patient is likely to tolerate those kind of exercises fairly well, given their low irritability and severity. There's no evidence either way really to support or refute strengthening of the ankle dorsiflexors. So may not be harmful to do that, but it's not going to be beneficial like answer number two is. And then there's actually weak evidence to support stretching of the ankle plantar flexors and soft tissue mobilization of the gastroc and soleus. And again, you can turn to the clinical practice guidelines to take a look at that. So Tone, I see you. Yeah, that was a good question. Yep. And just a reminder to everybody that this session is being recorded, and it may take a few days, but it will eventually be posted to TherapyEd's PT YouTube channel. So you want to take them 20, 30 minutes or however long to go back and review some of this stuff, then you have that opportunity. All right, let's move on. Question number 3.
Story, and you will vote.
All right, here's your poll. All right, go ahead and finish up. Get your answers in. All right, and go ahead and share the results on this one. And so CVF, so you've asked, yeah, how can you, on that last question, can you give an example on how to do a resisted uh, eccentric exercise for the plantar flexors? I mean, this is something that you could do in standing. Let's say that you actually have the ball of the foot up on a the front part of the foot up on a little bar on a little bit of a raised surface, and you could do toe raises, and then just making sure that you slowly and in a controlled way return back down to where you've got the heel touching the ground, or you could be on an exercise piece of exercise equipment like at the gym, like one that you would do a leg press on, right? And you could actually, and I'm sorry, this will be my foot, so I'm going to turn to the side here. So I've got my knee extended, so my knee is extended all the way, and I've so done a concentric plantar flexion contraction, right? And then I'm returning back as I'm returning back to kind of the neutral position of the ankle. That's going to involve eccentric exercise, right? And so you can do a combination of things there. So all right, so on this one, so this is one of those questions, and I alluded to this before, but there's a time frame that is actually mentioned. We're seeing this individual 24 hours after injury, and if we highlight some of the key findings here, what we should be thinking about is somebody that has an acute hamstring injury. So they had this, they were sprinting, had this sharp, sudden onset of severe pain in the posterior thigh, kind of classic mechanism of injury for somebody who has had a hamstring injury, and they get that bleeding and ecchymosis. But again, we're seeing them 24 hours after injury. And so let's take a look at how y'all responded. Most of you said that we want to be doing knee flexion and extension activities within the pain-free range. And that is indeed the correct answer. So great job on that one. And I think for those of you who answered the question correctly, you were probably tuned into the last part of the answer choice, right? We want to do things within the pain-free range. We want to make sure that we're that during this acute inflammatory period, 24 hours post-injury, so we're in the acute stage of healing, that we're letting things settle down. We're letting cross bridges form, right? We don't want to completely disrupt that inflammatory process. And and so working within the pain-free range and helping to maintain mobility and knee mobility and muscle length to an extent, that's going to be helpful. Now, some of y'all chose number one. Cross friction massage is a treatment that we often do with patients that have had a hamstring injury, but we don't do that 24 hours after the injury. As a matter of fact, I'd submit to you that if you do that cross friction massage to that patient immediately after their injury, they're going to think twice about coming back to see us, right? And so, when are we going to do that? We do cross friction massage so that we can prevent or manage scarring, prevent the development of adhesions, maintain muscle length, that kind of thing. But that's going to be later on. That's either going to be in the proliferative or the remodeling stage of healing. So maybe 2 weeks, 3 weeks down the road. And again, on number four, if we're doing active knee flexion, then that's probably going to be painful for the patient, and that's going to kind of disrupt that healing process as well. So keeping in mind these soft tissue healing timelines is going to be important. And again, if the author of a question made the effort to include a time frame, that's probably going to become an important part of answering the question correctly. All right, let's move on to question number 4. Here's the poll. All right, go ahead and finish up. Get your answers in. Okay, and here are the results. We got about 50 out of 59 people responded. So let's see. So in this one, this person they've got a 1 week history of low back pain. Pain radiates into the buttock and posterior thigh. And there are some key findings here, some findings that, if y'all are familiar with the clinical prediction rule by Flynn et al. And Childs et al. That talked about, when to manipulate somebody with acute low back pain, then some of those key findings are here, right? So symptom duration, that is So the person still kind of being in a relatively acute phase, pain that does not radiate distal to the knee, because if it radiates distal to the knee, we may be thinking more about somebody that has a radiculopathy or radiculitis. Limited range of motion. So when we do PA glides or our PIVMs on that person, they're in the prone position and we're doing those PA glides on their spine, we find that there's some stiffness, some limited mobility, it says in this case from about L4 to S1. So based on these findings, the PT determines that the patient will respond favorably to what? Spinal manipulation. Okay, and that's what about half of y'all chose on this one. And so again, I would encourage you to go back, take a look at the clinical prediction rule that was published by the preliminary one was published by Tim Flynn, and then it was validated by John Childs. And so there's good information there. And that kind of information has actually made its way into what I'm sharing with you here, the clinical practice guidelines. So there was a revision for this that was done in 2021, and you can see high level of evidence, right? Grade A evidence. So it says manual and other directed therapies for people with acute low back pain. Physical therapists can use or should use thrust or non-thrust joint mobilization to reduce pain and disability in patients with acute low back pain. The other answer choices, let me go back to those real quick. Stabilization exercises, we would have expected to see some signs or some indications in the question stem that this person had instability, right? Maybe a positive PIT test, prone instability test. Lumbar traction, the same thing. We're probably thinking about somebody that maybe has a positive straight leg raise or cross straight leg raise, maybe symptoms that radiate distal to the knee, uh, maybe clear signs of nerve root impingement. And with the extension exercises, again, we can think about things like the centralization phenomenon or directional preference and exercise preference. Maybe there was some clear indication in the question stem that that person had, they preferred extension exercises or they preferred flexion exercises. But everything that is highlighted in the question stem here is directing us to think about spinal manipulation. As the CPG says, it could be thrust manipulation, mobilization, or it could be non-thrust mobilization that's considered. All right, let's move on to number 5. Here's a poll. Okay, go ahead and finish up, get your answers in. Let time run a little bit long on that one. All right, here we go. So yeah, it looks like most of y'all were deciding between answer number 3 and number 4 on this one. So this PT is yeah, they're developing a treatment plan for a patient with fibromyalgia. So we didn't know that they have fibromyalgia. Which factor is going to be most important for the PT to consider when planning an exercise regimen for this patient? And so, so let's actually go through, I'll kind of go run through these answers in order. Number one, it says patients with fibromyalgia have difficulty with water-based or aquatic exercises. Actually, in individuals with fibromyalgia uh, actually do really well, and water-based or aquatic exercises tend to be particularly effective for the patient with fibromyalgia. And group sessions tend to be pretty effective for those patients as well. So there've been a couple of studies that demonstrate that. But most of your answers, again, came down to number three and number four. Number three says morning sessions work best for patients with fibromyalgia. Number four, patients with fibromyalgia have difficulty with sustained overhead activities. Number four is the correct answer on this one. I think with number three, it's probably good to think about, even though the structures that are involved are a little bit different, like patients that with osteoarthritis, about they're going to tend to have a hard time getting going in the morning. You may recall, and this relates to some of the signs and symptoms, features, and characteristics of the patient with fibromyalgia, but about 85% of individuals with fibromyalgia have sleep disturbances and sleep disorders, right? So they can have a hard time getting going in the morning. So kind of like the patient with arthritis, they may have a hard time getting going early on. Morning sessions, afternoon sessions may work a little bit better. Late morning or afternoon sessions may work better for the person that has osteoarthritis. Well, afternoon sessions typically are going to work best for patients that have fibromyalgia. So you can get a question that deals with the diagnosis of the disorder. We know that there are these tender points that you need to be. The criteria involves being tender in 11 out of 18 tender points. What else? We talked about sleep disturbances are fairly common. We often think of the disorder being seen more in females than in males. And if we think about age range, fairly wide age range, maybe about 36 to 60 years, maybe 30 to 50 is a little bit of a tighter age range for that individual. All right, two questions to go here. I promised you one on regenerative medicine, and here it is. You go ahead and finish up. As y'all are finishing up, yeah, Kelsey, I see your question there. Yes, picking the time of the session, you do want to take into account fatigue, but again, those individuals that about 85% of them have sleep disturbances and they have a hard time getting going in the morning. So they may potentially get more fatigued as the day goes on, but I certainly wouldn't want to do an early morning session. I mean, potentially late morning, depending on the individual, but I'd probably err on the side of thinking an afternoon session or an afternoon appointment would be more effective and more beneficial than working with them definitely in the early morning and maybe even more so than in the late morning. Yeah. Okay. All right, so let me go ahead and share this poll with you. And looks like most people chose that we want to discontinue NSAIDs prior to doing the platelet-rich plasma injection. Let's go ahead and bring in some of the keywords and everything. We know this person has knee pain. PRP injections could be effective with a person that has, or it's indicated. So when we think of knee pain, it doesn't give us a real specific diagnosis. Could be patellar tendinopathy, could be the person that has knee osteoarthritis. Those are indications, and we'll see a little bit of a summary slide about PRP injections in just a minute. But which statement most accurately reflects an expected adjustment in the patient's use of NSAIDs? Well, what most of y'all chose is exactly the correct answer. And so patients are typically advised to suspend the use of NSAIDs prior to a PRP injection because of the potential for the NSAIDs to diminish the effects of the injection. So NSAIDs, aspirin, and even acetaminophen may tend to decrease platelet count. And so and it does so through you may remember the whole arachidonic acid and cyclooxygenase, that mechanism. That's what many NSAIDs, how they work. Those that are on like COX-2 inhibitors, those selective NSAIDs like Celebrex is one that comes to mind. I take Celebrex for back pain and neck pain, and so COX-2 selective NSAIDs, uh, maybe those could be continued, but otherwise, generally, NSAIDs are going to be discontinued. Ibuprofen and aspirin they're going to be discontinued to prior to having the injection for the reason that I mentioned. And so, really, all of the other answer choices imply that NSAIDs are still going to be taken when we want to go ahead and shut those off. And so here's a nice little one of our instructors came across this online and just talks about some of the mechanisms and everything and what happens. And platelets are well known for their clotting abilities, but they also contain growth factors that can trigger cell reproduction and stimulate tissue regeneration. And so that's the reason, really the basis, kind of the key foundation for doing these platelet-rich plasma injections. Some of the clinical applications, if you look at the image that is on the left and you look down towards the bottom, we think about people with tendon disorders, hamstring injuries, even. We had the question about that a little bit later. And then knee osteoarthritis. So those are some pretty good clinical indications. And I suspect that a number of y'all that's consistent with what your experience has been in the clinic as well. All right, so remember, PRP, regenerative medicine, stem cell therapy, ACI, MACI, those are all going to be new, and you may see potential questions related to those on the examination that you're going to take. All right, little drum roll. Last question of the evening, number 7. Okay, go ahead and finish up. All right, so about 90% of y'all have responded to this, and uh, most of you chose, about 80% of y'all chose number two. Let's go ahead and see if that is the correct answer. Now, shame on me. I snuck in a little bit of a curveball here, but want to keep y'all on your toes. We've been answering questions about musculoskeletal problems, and I wanted to I deliberately switch gears on you a little bit just to make sure that we're we're thinking about what are some potential conditions that may masquerade as a musculoskeletal problem, and that's what we're dealing with here. So in this question, this PT examines a 65-year-old male who is overweight. Let me go back to so just that part, 65-year-old male. So typically, most of the questions are going to say things like an adult patient, but if we see age and we see gender specified in a question stem, then that's likely going to have an important part or play an important role in terms of you answering the question correctly. So this person has low back pain. It's described as a deep ache and throbbing. And so it says there are no specific factors that aggravate or ease the 7 out of 10 low back pain. So 7 out of 10 is fairly intense, fairly severe pain. And it says there are no specific factors that aggravate or ease the pain. Well, that's a little bit unusual, isn't it? For when we think about most patients that come into the clinic that are complaining of low back pain, they can tell you it feels better when I do this, it feels worse when I do that, right? And what else? There's that throbbing descriptor that's kind of a key part of answering this question as well. The therapist is unable to change the patient's symptoms with any type of position changes, functional tests, or other measures. So another way to say that is that patient's symptoms are pretty constant, right? We can't change them. And for those of y'all who have taken our 2-day prep course, you may have seen this, or you would have seen this question before. It may be a new question to others, but the correct answer on this one is what most of y'all chose. And go ahead and light up the chat box if you would. What do you think is going on with this patient? You didn't need to come up with a specific diagnosis to get the question correct. So say, okay, so I see a bunch of y'all. So yeah, abdominal aortic aneurysm. That's exactly what we were going for. That throbbing descriptor is going to be consistent with a triple A. So well done. And again, you didn't need to come up with the diagnosis. Maybe you were thinking that it was, cancer. Maybe the person had a tumor in their spine. But what you should have been thinking at least is this does not sound like a musculoskeletal problem. If you chose number one, number three, or number four, then you were looking at it like it was a musculoskeletal problem, but that is not what is being described here. So, yep, a triple A is what we were going for. And I just to follow up on number four in particular, where it says recommend an X-ray to rule out a possible lumbar spine fracture. If that person had a fracture of the lumbar spine, they're probably going to say there's some aggravating factors and easing factors. The other thing is, if you look at the question stem, it says that the therapist was unable to change the patient's symptoms with any type of position changes, functional tests, or other measures. If they've got a fractured lumbar spine, we're probably going to send them through the roof, right? Their pain level is probably going to go through the roof if we maneuver them around and have them flip from prone to supine and that kind of thing. It's probably going to be pretty aggravating for that individual. So yeah, just to review real quickly, signs and symptoms of an abdominal aortic aneurysm, you're going to hear words like pulsating and throbbing. The patient is unable to find a comfortable position, which is kind of what that person was describing. We see it in males 6 times more so than in females in age greater than 60 years. And then, some of those other cardiovascular risk factors. But this is from let me bring my laser pointer up here. But yeah, this is from a CT from a paper that was published by, I believe it was Bill Boyce and all way back in 2008. But we can see the spine here. You can see the heart. You can see the aortic arch and the descending aorta. And there's a kidney, the right kidney in this case. We get down to this point, right? That is not the stomach, as the arrow and the label indicates, the caption indicates. That is an abdominal aortic aneurysm. And we got to be good at picking up on these signs and symptoms because, I mean, if that patient walks through our clinic doors, we got to recognize that that's not run-of-the-mill low back pain that we're dealing with. I mean, no low back pain is run-of-the-mill, but that is not a musculoskeletal problem. We got to get that person tended to in an emergent type of way, because if that aneurysm bursts, that's it, more than likely for that patient, right? And so we got to keep our antennas up. And where does this come into play? When we're thinking about the NPTE, safety, right? So recognizing signs and symptoms of non-musculoskeletal problems, red flags, all that kind of stuff, we got to be good at picking up on it. All right, so let me go ahead and shut. That was our final question. And just as a matter of review, we kind of brainstormed, or I brainstormed, as to what are some potential type questions you might see in terms of interventions. And we couldn't cover every type tonight, but we covered, I think, a pretty representative sampling. And so with that, does anybody have any questions before we probably got about 2 minutes or so to go here? Any questions before we wrap things up? And I see y'all saying thank you. Thank you for joining us tonight. And good luck to each and every one of you, especially those of you who are going to be taking the examination coming up at the end of April. And tune in next week. We got a couple more sessions to go before the April exam, and plenty more online office hours to cover before July and before October and before 2025. So, all right, y'all have a great night. Thank you, and best wishes for success on the NPTE. And Emma, thank you for your kind comment there. I appreciate that. Always enjoy. Good to see your name again, and enjoyed my time there at UNF. Yep. All right. Good night, everybody.